All right, so welcome and thank you for attending today's webinar on useful tools for a compliant Medicaid provider. My name is Melanie Donnelly and I work in the Medicaid Fraud Division. And today's training is tailored specifically for you, for partial care providers who provide services to New Jersey family care members. And as I mentioned, today's presentation is being recorded, and following the presentation, the slides you are about to see will be circulated to you by email. We will also be posting them on the Office of the State Comptroller's website, so they will be accessible in the future. So today we're presenting to you in partnership with a number of New Jersey state agencies and key stakeholders of the New Jersey Family Care Program. And this includes the Department of Human Services, Division of Mental Health and Addiction Services, the Department of Human Services, Division of Medical Assistance and Health Services, where I'm at, which is the Office of the State Comptroller's Medicaid Fraud Division, the Office of the Insurance Fraud Prosecutor Medicaid Fraud Control Unit, and last but not least, the New Jersey Family Care Managed Care Organizations. And before we dig in, we do want to say thank you to all of the partial care providers who are on this call and who participate in the New Jersey Family Care Program, as well as the staff who coordinate services for the New Jersey Family Care members. We know the last few years have been very challenging, and we want to express our gratitude for your commitment to our patients. And a bit of housekeeping before we begin. This presentation is intended for general educational purposes only, and it does not replace your responsibility to seek professional guidance, observe all laws and regulations that pertain to your practice as a Medicaid provider, and exercise professional judgment. Throughout this presentation, the words Medicaid and New Jersey Family Care might be used interchangeably. New Jersey Family Care is the name of the Medicaid program in New Jersey, which includes Medicaid, CHIP, which is the Children's Health Insurance Program, and Medicaid Expansion. Medicaid services are provided through the state as well as through the 5 Medicaid Managed Care Organizations, or MCOs. So just wanted to be clear so there was no confusion on Medicaid versus NJ Family Care. And the goals for today's presentation are to help you better understand partial care providers' responsibilities for Medicaid compliance, the Medicaid regulatory framework and program integrity oversight, Medicaid documentation requirements for payment, provider obligation to avoid fraud, waste, or abuse of Medicaid funds, and the consequences for non-compliance. If you have questions throughout the presentation, please enter them in the Q&A. We will have somebody monitoring that for you, and we hope to get back to you. If not during this presentation, we will take it back, and as long as your email address or your name is included, we will have a way to follow back up with you after the presentation. In addition, at the end of the slides, we will also share a contact email address that you can jot down and use for future questions. So now that the housekeeping items are out of the way, let's dig in. And we're going to start by briefly addressing what is Medicaid. Medicaid is a jointly funded federal and state program that provides funding for medical costs and specialized services for eligible individuals. And this participation is voluntary. If you want to participate, you must know, accept, and abide by the rules and regulations. And continued participation requires compliance with the regulatory requirements. This slide provides an overview of the New Jersey state agencies that are involved in oversight of the Medicaid partial care program. So starting on the left, you'll see the Department of Law and Public Safety, which houses both the Medicaid Fraud Control Unit, who you'll hear from later today, which is the criminal arm of the Medicaid oversight, as well as the Division of Consumer Affairs, which is for the licensing boards. And then moving towards the middle, we see the Department of Human Services, which is what probably most of you are most familiar with. And that encompasses both the Division of Mental Health and Addiction Services, as well as the Division of Medical Assistance and Health Services. And then continuing on, the Office of the State Comptroller is an independent state agency, and it's probably not as familiar to you. Within the Office of the State Comptroller is the Medicaid Fraud Division, and that is the civil arm of Medicaid oversight. And we'll learn more and talk more about the Medicaid Fraud Division later in this presentation. And last but not least, along the far right is the Department of Health, which contains facility licensing as well as the partial care program's triennial audits, which are conducted by Certificate of Need and Licensure. So that just gives a bit of an overview and includes many of the agency partners that you'll be hearing from today. And now I'm going to turn it over to David Helfand, who's the Assistant Director for the Office of Community Services at the Division of Mental Health and Addiction Services.
Thank you very much. So just continuing that line, I wanted to give a little bit of background about who we are. And as Melanie said, we really work in conjunction with these other entities to monitor and oversee the services that you provide. So the divisions, this is the division's mission statement. And the points to take home is that we're really working with a pretty vast population with complex needs. We focus on, wellness and recovery. So our mission and really what we believe is that individuals can and do recover from their mental health diagnosis. What that recovery is and looks like may be a little different for everybody, but it's how we focus on the services that we contract for. So folks may have an array of needs, such as co-occurring needs, as you know, and we contract to provide services to those individuals that may provide an early intervention or treatment and recovery focus service. So if you go to the next slide. So this really just kind of echoes that point. The individuals you work with in partial care, as you well know, have a lot of overlapping issues. Certainly individuals with a mental health diagnosis, many have a developmental disability and a mental health diagnosis. Our division doesn't directly work with individuals until they're 18, but certainly we have services under our children's system for those that are children or adult or adolescents that may be dealing with a mental health issue. Seniors have very specific mental health issues they often confront. Many individuals who have a mental health diagnosis have housing issues, as you well know, and that's one of the bigger challenges I think that we all face is assisting with housing. And as mentioned earlier, many have a co-occurring substance use disorder that I know it's being addressed through the partial care or other methods. And then there's those with legal issues. So, the mental health system is pretty vast. This is kind of a really simple breakdown of the different levels of the system. And as you'll see, many of these may be sources you either refer to or receiving referrals from at times. So every county has a screening service. Their job is a difficult one, is really to determine whether an individual meets the commitment criteria to be hospitalized. So it's certainly possible somebody may be seen by screening that you're already working with. You may call them. They may do mobile outreach to your facility, or they may make a referral to one of your programs. Then there's inpatient treatment, pretty self-explanatory. That's generally your short-term care psychiatric units in each county. There's also the state hospitals and diversion hospitals, and in some counties, there's county hospitals. Then outpatient treatment services has a pretty wide array of different types of outpatient treatment services. There's typical outpatient that you may know with a psychiatrist and a therapist. There's more intensive versions of that, such as what we call IOTSS, Intensive Outpatient Treatment and Support Services, or EISS, Early Intervention and Support Services. Partial care really falls under our category of rehabilitative services, where the goal is really to help the person meet their maximum potential. And as you know, partial care can be up to 5 hours per day, up to 5 days a week. Many of the services are group-based with medication and there's transportation. And lastly, we have services of advocacy and linkage. Often in many of your counties, we contract with legal services to provide free legal assistance for those maybe applying for Social Security and have an appeal determination. And lastly, self-help. We have an array of self-help services. And every county actually has a self-help or wellness center, which is run by peers. And it's basically a home where individuals can go and receive peer support, which can really sometimes be an enhancement to some of the services they get in outpatient or partial care. So in New Jersey, partial care services are provided through fee-for-service, with some populations covered through managed care. And I'm going to hand this over to Steve in a second, but I just want to say, we do contract with some entities to provide partial care services. Certainly, there are many that do not. And the ones we contract with, we contract through a fee-for-service network where they can bill the state for those that do not have insurance for the services on a fee-for-service basis. So I believe this is where I will hand this off to, I believe, Steve.
Thanks, Dave. Hello, everybody. I'm Steve Tunney, Chief Behavioral Health for New Jersey Medicaid. And I'm going to start off going over the 21st Century Cures Act. Effective January 1st in 2018, the 21st Century Cures Act required all Medicaid providers to be enrolled with the state Medicaid program, where risk being removed. And this included managed care network providers as well. If you are a managed care only provider, then the enrollment process is just for Medicaid to vet you and check for disqualifying information. So enrollment in the state Medicaid program as part of the 21st Century Cures Act does not require a provider to accept Medicaid fee-for-service. If you did wish to participate and accept Medicaid fee-for-service, you would need to complete the full application. The 21st Century Cures Act is only if you want to be a Medicaid managed care provider, and that's it. So enrollment as a 21st Century Act provider does not allow you to bill Medicaid fee-for-service, only the MCOs. And if you want more information on this, it's listed in newsletter volume 30, number 18, which is found at www.njmmis.com. So Medicaid currently contracts with 5 MCOs: Aetna Better Health of New Jersey, AmeriGroup New Jersey, Horizon New Jersey Health, United Healthcare Community Plan, and WellCare Health Plans of New Jersey. All 5 plans also have a DSNP, which also covers partial care services in New Jersey. So the partial care services that are covered by the managed care plans are basically the same exact services covered by fee-for-service Medicaid. In the majority of services are covered fee-for-service. We have 9,400 members who received partial care services last year. The managed care plan provided services for 1,600 individuals, just to give you an idea of where we're at. Currently, only the special populations are covered by managed care. These include MLTSS, which is Managed Long-Term Services and Support, DDD, which is the Division of Developmental Disabilities. You do not have to be actively receiving services from the Division of Developmental Disabilities, but you have to be known to them, have to have applied and be registered in their system. And then finally, the FIDE SNP, which is the fully integrated dual eligible special needs program, which is essentially the combination of your Medicare and Medicaid benefits. So these special populations receive their partial care services from providers who must be contracted with the member's managed care plan. The benefit, as I said, is the same as it is for fee-for-service, and the billing code is the same with H0035. So the partial care services that are covered are subject to prior authorization. That's a requirement under fee-for-service, and I believe all the MCOs also require prior authorization. The authorization will give you a reference number if you get it through the managed care, which will tell you the type of service, the specific billing code, the start and end date, and the number of units that you're allowed to provide. Make sure you have that information and that's included when you submit your billing. You should know your authorization details and when the updated clinical is due for concurrent review, as well as your next prior authorization request. So partial care services covered by the MCOs are limited to 5 hours a day, 25 hours a week, just like fee-for-service. The partial care transportation that Dave references available to everybody in partial care is only covered through fee-for-service. So even if your partial care is covered by the managed care plan, you would bill fee-for-service if you're a fee-for-service provider to get the transportation services covered, and you would bill with Z0330. This service is not available under the Mfd care contract, sorry. As part of the proposed 1115 waiver, partial care services may be covered by managed care for the total Medicaid population. Gotten several calls on this. There is no timeline as of right now. What we did was request permission to do this. There will be extensive reach out and stakeholdering with the community before that happens. I just want to make sure everybody's aware of that. The partial care regulations that oversee partial care services are in all three divisions. The Division of Mental Health and Addiction Services is under 1037F. Medicaid, you find them in our independent clinic manual 1066-2.7. And the Department of Children and Families has partial care regulations under 3A58. If there's ever a conflict between the regulations, I always tell people go with the most stringent. We do our best to keep our regulations in line with each other, but occasionally there may be a little bit of a difference. So if one reg says you have to do it in 2 weeks and the other one says you have to do it in 3 weeks, do it in 2 weeks. Newsletters are used to introduce any new programs or services, pending regulation updates, or general program guidance. So when we intend to change our regulations, we generally come out with a newsletter first. This is important because actually getting regulations through takes a very long time. So make sure you check newsletters. They're sent out by Gainwell, and they go to everybody who's a registered provider. They can also be found on www.njmms.com. On the left-hand side, it says newsletters and alerts. The guiding regulation for partial care services, it's your responsibility to observe the regulations. I'll speak for the Medicaid regulations, which address everything below. The regulations dictate who can provide the service. So you have to be a Medicaid contracted provider, and by Medicaid, I mean managed care and or fee-for-service. Who can receive the services? Anybody that's in Title 19 or Title 21 Medicaid. What are the limits on services? Currently, it's 5 hours a day, 25 hours a week. Allowable versus non-allowable services. It's easier just to say non-allowable services would be you can't provide educational services and bill for them. Children can't go into a program and do homework, for example, and we do not pay for social activities. It has to be a therapeutic rehab service in order to bill for that time. The documentation requirements under Medicaid are daily. And when I say a daily note, that's where you just have to record the who, what, where, when, and how. A lot of people in partial care do it through a checklist type of a thing. So you would have the name of the program, the length of the program, how long it was. It could be 1 hour. You can either put the start and end date or just put the time frame, as long as you're identifying how long the service was, who provided it, what was provided, and what the intent of that service is. Another documentation requirement, which is a big one, is that you have to make sure that all the services provided are linked to the individual's individual treatment plan. So if it's not written in the treatment plan and you provided a service on anger management, it's not addressed in the treatment plan, and we get audited, OIG, which is the federal auditors, have been disallowing those services. They only want you to provide services that you identified as needed and are listed in the treatment plan itself. So make sure that you get that in there. If it's a one-time deal, you can do something unusual happens, you don't expect it to happen again, just put a progress note. But if a new problem develops and a person starts receiving routine services for that, make sure you do an updated treatment plan. Frequency guidelines and then the billing codes are also a requirement. Talk a little bit about the public health emergency. As you know, New Jersey ended our public health emergency, but the federal public health emergency is still going, and the Department of Health is still requiring the individuals that they license to maintain certain safety restrictions. So the big ones are you have to maintain the 6 feet spacing when individuals are in the program. Individuals within the program are expected to wear masks, and vaccines are mandatory for staff, not for the members that are attending. Telehealth currently allowed, and that was something that we put in to help programs stay viable during the height, I guess you would call it, of COVID. We've asked programs to start reopening, and a newsletter is ready to go out any day now, and it will announce that the per diem payment will be terminated effective August 15th. So anytime after that, any data service after that that is billed, you won't be able to bill for the per diem. We're going to go back to the in-person hourly billing. You can still do telehealth. If you do a telehealth service, primarily like if a physician did medication management, that can still be done via telehealth. It has to meet all the same requirements as a face-to-face visit. It has to be documented that it was telehealth, but you can bill for that time. It would count. Billing for the actual partial care programming itself, the group programs and stuff, I know is difficult, but we're trying to move the programs back into getting the individuals that 5 hours a day. The telehealth law, if you're aware of this or not, was updated. There's a 2021 version. The good news is that does allow for telephonic services to continue. It does not have to be video option unless the provider feels that that's required. So a lot of the onus is put on whoever the professional is that's ordering or providing the service, that they have to make sure that the individual can provide that service at the same level of quality as they could face-to-face. And the last slide, the 6 steps towards compliance. So you need to provide clinically appropriate service as identified in the treatment plan. Again, that's a key. This is something that we've gotten hit by federal auditors on hard. You have to make sure that it is a clinically appropriate service, that it was identified as a patient need, and that it is being addressed specifically in the treatment plan and in the progress notes that address that treatment plan. You have to accurately document the service. That's the who, what, where, when, and how. And you have to institute responsible billing practices. So don't bill by exception. There's programs that, well, if somebody doesn't tell me that the person wasn't here, I'll just bill for them. That's not a responsible billing practice. You should be billing for those services that are documented or shown did occur for each individual. Properly supervise the employees for the provision of services. Make sure that they are documenting daily, that they're not missing days, that all individual sheets from programs are available in the event of an audit so that you can demonstrate that the person did receive those services. Establish a system to identify and correct errors and omissions concerning credentialing. This is a QA function. You could have a person that's responsible to go through and review records. And if you see that there's dates that are missing, signatures or actual notes or whatever the case may be, somebody was due for a medication management and it wasn't provided, that's a quality assurance function that you can take on. And lastly, adhere to the waiver and regulatory standards whenever applicable, and include that in your hiring practices. Make sure that people are properly credentialed, completing the Medicaid application, and make sure you're providing adequate training to yourself and your staff about all the requirements required to provide partial care services. So I'll hand off next to Vinny Visioli from Horizon.
All right, Steve, thank you very much. Can I be heard okay?
Yes.
Okay, all right. So my name is Vincent Visioli, and I am the Manager of Regulatory Affairs and Behavioral Health Operations for Horizon Blue Cross Blue Shield of New Jersey. I'm going to take us through the next couple of slides here. And the slides I'm going to cover here have to do with accurately documenting services, and then we'll get into record retention requirements and some of the applicable timelines there. But if we look at this first slide here on accurately documenting services, you can see that these documentation requirements arise from a variety of sources, including state and federal statutes, state Medicaid and federal regulations, including CMS regs and policies, state professional board regulations. But these documentation requirements can also be found in your contracts and provider agreements with your MCO partners, as well as in the provider manuals and some of the other communications that the MCOs publish. The point is here that you always want to keep in mind the industry best practices when thinking about these documentation standards. And these are some of the sources where you'll be able to reference them. Next slide. Yeah. This slide here just talks about how it's the responsibility of the provider to know about and comply with documentation requirements. So I definitely would encourage everyone to go in and look at some of the sources that were just referenced on the previous slide, and familiarize yourself with some of the state and federal statutes and regulations, as well as the MCO materials, just to ensure your organization is documenting things in accordance with those requirements. One of the things that we used to do back in the day when I worked for and eventually ran a number of different programs that included partial care, we used to, very similar to what Steve was just mentioning, we used to conduct regular quality assurance assessments to ensure documentation met the standards set forth in the statutes and regulations, and that included assessing that staff were documenting accurately and timely at the time that the services were rendered. And sometimes these assessments included interventions up to and including corrective action plans to address any deficits that might have been found to to ensure our documentation was accurate, timely, and up to snuff. So hugely important to be aware of and be in accordance with the documentation requirements set forth in the regulation, and to ensure your organization is in compliance with those. Next slide. Yeah, in terms of record retention guidelines, here the timelines really vary by the source, as well as the age groups that the records pertain to. And here the regulations that pertain to adults state that records need to be retained for a minimum of 5 years after the last date of service, whereas for children, it's 5 years after their 18th birthday. Article 728A of the MCO contract requires 10 years. So the best rule of thumb I can offer, similar to what Steve was describing in his part, is to follow the regulation that requires the greatest length of time that pertains to your organization and the population to serve, and to err on the side of caution. It's generally better to be on the safe side there and follow the more stringent standard if there's any difference in the regs, about what standard applies. Next slide. Yeah. This slide here just shows that in adhering to the Medicaid documentation requirements, providers are adhering to really 3 things. One, to keep records, to disclose the extent of services provided, as well as individual records for the greatest time that applies from the date services were rendered. 2, to furnish any information that might be requested by the Medicaid Fraud Division, and to do so in a timely manner. And then 3, to be cognizant of the fact that if the records do not document the type and extent of services billed, that payment adjustments might be necessary, including repayments to Medicaid or claim payment denials from the MCOs. So really just, really critical to ensure your organization's documentation is up to standard and that your procedures around documentation and record retention are all in line with the applicable standards as well. And I think that is it for me. So with that, I will pass to my colleague from United, Gail Parker-Wright. Yeah.
Thank you. Thank you, Vinny.
Sure.
And so I'm just going to continue on from where Vinny left off as it relates to documentation and its requirements. So generally, there are 2 types of medical records. There's the handwritten, which, we're not so great about, right? But we do. And then there's the electronic health records. And so regardless of the type that you utilize, the content must be accurate and it must be complete. So what are some of the things? It must be record the diagnosis. Fully disclose the kind and extent of the service provided, as well as the medical necessity for the service. Also, you want to make sure you include in the notes what occurred and when appropriate and what expected outcomes. So the records must document all services billed, including time if required for a billing code. Next, thank you. So we want to make sure, again, that the notes are accurate and detail the services that were provided. You want to make sure it's clear on the continuity of care by your agency and or any other providers. Also, to properly support the services that are being billed and rendered. That's really important. The other thing is the progress notes in the billing records are 2 distinct documents. We don't want to get that confused. So both may be requested at times. So make sure that those are written and clear. All records and documentation used to support billing must be what? Individualized and reflect the actual services delivered. So it has to include the individual's name, the date of service, time, duration, the specific services rendered, such as whether it's individual, group, or family psychotherapy and such. The description of the encounter, and it must notate any unusual occurrences. The signature of the person authoring the note, as well as a supervisor's signature, if applicable or if it's required. Also, the record must reflect all elements from which the provider bills, which is you, right? So it should be done at the time the services are rendered and as close as possible, or at least as close as possible. So sometimes we understand that situations take place or happen, but we want to make sure that we stay within the parameters needed. Time-based codes require documentation of the time. So documentation of the time can be on a separate document in the patient's record, but it has to be recorded. So if you're using handwritten records, your content and your signature in the notes must be legible. I know some of us have that signature we practiced since we were younger, right? Next slide. But also your notes must align with the services or the treatment plans and the outcomes and strategies. Also, it must answer the what, the who, the what, the when, the where, and the why of the service provision. And it must be completed by either the individual providing the service or an individual responsible for the oversight of the direct service provision. So if the note is completed by a staff member not providing the direct service, they must and they should have documentation to support the information contained in the note. Also, it must reflect, the progress notes must reflect toward or decline from identified outcomes. That's really important. Also, it must comply with the partial care requirements as detailed by New Jersey AC 10.66-2.7 and New Jersey AC 10-1037F. So some of the other things the notes must be. You as providers using any electronic health records or any electronic system must ensure that all the information required in mandatory sections is included and individualized for the recipient, and that all underlying documentation can be produced to support the services rendered during whether it's an audit or an investigation. Also must be completed, all notes must be completed by a staff member not connected to the service provision. Okay, that means that, I'm sorry, cannot. So these are notes that cannot. These notes cannot be completed by a staff member that is not connected to the service provision. The notes cannot also be duplicative or generic in nature. So what do we know? We know the records and the documentation must be accurately reflect the services that were rendered. We know that documentation should occur at the same time as services rendered. And we know that Medicaid will not pay for undocumented or improperly documented services. So what do we all know, right, from school? We share this with our staff. We know this from time. Don't shortchange yourself. If it's not documented or it's not documented correctly, then it wasn't done. Now I'm going to turn it over to my colleague. Thank you.
Thank you, Gail. Hi. Hi, everyone. I'm Dorota Gogolowski, auditor at the Office of the State Controller, Medicaid Fraud Division. And I will talk about the chart requirements and the billing requirements. So as we have said before, all of the entries should be legible. If we can read them, we can read them. Each patient chart should contain psychiatric evaluation and intake form completed within 14 days of initial date of service. It should also include plan of care, which was discussed, accepted, and signed by the patient, medical director, and licensed clinician. Plan of care should be reviewed and updated every 90 days during the first year and every 6 months thereafter. Prior authorization should also be part of the patient chart, and it is important to remember that new prior authorization should be obtained every 6 months, and billing should not exceed prior authorized number of units. Clinicians should always sign or initial entries in a patient file. Patient chart should also contain informed consents, if necessary, daily group notes, weekly progress notes, accurate description of treatment, and any other documentation supporting all services billed. Next slide. Billing guidelines. All partial care services must be prior authorized and should not exceed the total pre-authorized number of units within the authorized time frame. Partial care services are billable per hour with a maximum of 5 hours of service a day and a minimum of 2 hours a day. If the number of hours of service provided is fractional, the units should be rounded down to the lower whole number. So if you provide, let's say, 2.5 hours of service, you can only bill for 2 hours of service. Billing for partial care services is for active programming only, and that is exclusive of meals, breaks, and transportation. Billing and coding. It is important to know that codes you are billing for are correct and for the services you are providing. Codes that are for partial care includes H0035, H0035 GTUC Telehealth, which was used during the public health emergency, and the transportation code Z0330. It is provider's responsibility to ensure that claims submitted for payment reflect, once again, who, what, where, when, and how. So the actual service that was provided, who performed the service, the location of the service, the billing entity, and the time duration for claims that are time-based. It is provider's responsibility to be knowledgeable regarding the codes that are used to reflect the services rendered. If it's not part of your practice, it might be a good idea to implement a system of quality assurance and oversight that reviews compliance on an ongoing basis and make any necessary adjustments of service delivery to maintain outlined standards. Supplemental documentation to a note can be added if necessary, as long as the date of the addition is included, as well as the initials of the person supplementing the record. The regulatory standards. It is provider is responsible to verify with documentation that staff is qualified and trained, and verify their credentials, certification, licenses, and establish proper training schedule. Background checks should be performed, ensuring that new or potential staff have no disqualifying criminal issues before permitting provisions of service. Exclusion checks must be performed monthly and in accordance with the newsletter, NJMMIS newsletter, volume 26, number 14. Consequences. Non-compliance with Medicaid rules, standards, and regulations regarding service may constitute acts of fraud, waste, or abuse of Medicaid funds. And I will turn to Tracy now.
Thanks, Dorota. So I'm going to talk a little bit about the Medicaid Fraud Division. Melanie mentioned this earlier in the presentation, and this is especially for those of you who maybe haven't really heard of what our role is. In the state of New Jersey, we're under the Office of State Comptroller. And the Office of State Comptroller, anything that has New Jersey money, state money that flows through it, as far as contracts, as far as anything that has money involved, is actually monitored by the Office of State Comptroller. The Medicaid Fraud Division is underneath the Office of State Comptroller, and how we fit into that picture, we're really looking at Medicaid dollars. So anything that Medicaid dollars touches in New Jersey, it's something that the Medicaid Fraud Division that we look at. As you can tell from this slide, we started from the Medicaid Program Integrity Protection Act, and that act really established the Office of the Medicaid Inspector General. And then as time went on, these powers were transferred over to the Office of State Comptroller, which are carried out by MFD today. Now, the Medicaid Fraud Division performs integrity functions, conducts audits, investigations of potential fraud, waste and abuse by providers and recipients, and coordinate program integrity oversight efforts among all state agencies, and provide and administer Medicaid services and programs. In a nutshell, what this really means, the Medicaid Fraud Division is basically the gatekeeper for a couple of things in New Jersey. One in particular, the managed care organizations. The Medicaid Fraud Division works with the managed care organizations. The Medicaid Fraud Division also works with what we call MFUCU, which is the Medicaid Fraud Control Unit. We coordinate with all those agencies to make sure that we're all looking for potential fraud, waste, and abuse. So the Medicaid Fraud Division is right in the middle of those efforts. The Medicaid Fraud Division also works to recover improperly expended Medicaid funds, enforces Medicaid rules and regulations, audits, cost reports, claim review, and quality of care. Now, this is a really important function of the Medicaid Fraud Division. Looking at anything that has Medicaid dollars, it also includes audits, it also includes cost reports, it also includes data. So in other words, with Medicaid data, you have claim data from the bills, you have recipient data, and the Medicaid Fraud Division looks at all of that to make sure that everything is accurate. So when we're looking at potential fraud, waste, and abuse, we know that the information we're looking at is accurate and good to go. Okay, I'm going to pass this over now to Michael, and Michael's going to talk a little bit more.
Hi, my name is Mike Gaudino. I'm a senior investigator in New Jersey WellCare, and I'm going to start out with fraud. Fraud is an intentional deception or misrepresentation made by any person with the knowledge that the deception could result in some unauthorized benefit to that person or another person, including any act that constitutes fraud under applicable federal and state law. Civil Medicaid fraud, waste, and abuse consequences would include civil judgments and liens, exclusion from the Medicaid, Medicare programs, suspension or loss of professional licenses, referral for criminal prosecution, restitution, and/or recovery of overpayments, additional penalties in addition to repaying Medicaid overpayments. Waste. Waste is generally understood to encompass overutilization or misuse of resources. Waste is not usually considered a criminal act. Waste is considered a legal violation for civil purposes and can result in a recovery of an overpayment, debarment from the Medicaid program, and penalties. Abuse. What is abuse? Provider practices that are inconsistent with proper, sound, fiscal, business, or professional or service delivery practices that result in unnecessary costs to or improper payment by Medicaid, or reimbursement for services that are not necessary, not approved, not documented, that are outside those specifically authorized. Waste and abuse. Professional due diligence. Business practices that result in waste and abuse can rise to the level of fraud. Providing services without proper authorization, unless it is emergent care. Using unlicensed, unqualified, or untrained staff. Inaccurate, incomplete documentation of services. Billing for undocumented, unsubstantiated services, and insufficient internal checks and balances. And I'm going to pass it to Dorota.
Thank you, Mike. So some of the examples of partial care, fraud, waste, and abuse might include upcoding, misrepresentation in rendering provider, and billing for services not rendered, overlapping session times, or multiple family members for the same family therapy session. Some of the examples of inappropriate findings include, but are not limited to, claim date of service not matching chart entry, non-credentialed providers treating members, signatures that are not dated, missing time and service duration, reporting participants' presence in multiple group offered at the same time, reporting participants' presence at the group sessions offered prior or past participants' arrival or departure time in the facility. Two separate facilities billing for partial care services on the same day for the same member. Billing for partial care services during mealtime, as well as billing for intake assessment on the same day with partial care services codes 90791 and 90792 with PCP. Billing evaluation management codes for routine follow-up visits that were included in the partial care provider bundled rate. Now, I would like to go over some of the examples of the Medicaid Fraud Division's partial care audit findings. Up to date, we have audited some of the larger providers as well as the smaller ones, and we wanted to share the most common findings. We can't stress enough to keep your documentation organized so that you have a support for all of the services provided. Keep in mind that auditors have no other ways, other means of confirming whether service was provided or not, but through the review of the documentation provided by you. First and the most common audit finding is a lack of a documentation supporting billing for active programming. When we review the documentation you provided, we are not only looking to confirm participants' presence in the facility, but also their participation in the program. When services are provided in a group setting, many times providers are missing group sheets for some of the groups attended by the participant on a particular day, which results in us giving you a partial credit for that day. So for example, you have billed for 5 hours a day, yet your documentation only supports billing of 3 hours a day, which results in 2 hours of undocumented service. If service is undocumented, it is as if it didn't happen and is treated as an overpayment that needs to be returned back to the Medicaid. Another common audit finding is a mealtime that is included in the billing for active programming. The regulation strictly says that partial care services are exclusive of meals. Therefore, for example, including breakfast time in your active programming is not permitted. Another one is billing for active programming during participants' absence. That's a pretty obvious one. I don't think I need to add anything here. If participant did not come in, then don't bill for the services. Many times we also see a documentation lacking date, time, service duration, and counselor's signature. When we review documentation, we are always trying to give you as much credit for a service provided as possible. However, if a group sheet provided is missing group start and end time, we have no way of knowing the duration of that service provided to give a proper credit for that service. Similarly, with inclusion of date on all of the documentation you upkeep, if documentation is lacking a date, it is impossible to know when service was actually provided. Another common finding is properly documenting actual time of participants' attendance in a group. We understand that especially when it comes to a first class of the day, some of the participants can be late, and although class started at 9:30 and ended at 10 a.m., since participant arrived at the facility at 10 a.m., he or she was not able to participate in that class, yet they were marked present. According to the documentation. Similarly, at the end of the day, participant is marked attending a class, yet based on some other documentation provided by you, participant already left a facility at the time when that class was offered. And in those instances, the credibility of the provided documentation might be questioned since the two documents are conflicting each other. Similarly to those instances where participant is recorded attending two different groups that are offered at the same time. If it happens that for whatever reason, participant leaves one group and decides to join a different group offered at the same time, it would be a good habit of making a notation of such group transfer on the group sheet. This way it is clear to the auditor that participant was attending only one group and was not mistakenly marked present in two groups. One last example, even though it is not included on this slide, involves a billing within limits of prior authorization. We have performed many desk audits where we see providers exceeding their prior authorized number of units, which results in overpayment that needs to be returned back to the Medicaid. As you know, prior authorization specifies the number of units that can be billed for a specific participant within a specific time frame. Therefore, for example, if participant was pre-approved for 520 units within a 6-month period, yet you have billed for 540 units within that 6-month period, you billed for 20 units in excess of the prior authorized number of units, and a total amount received for those 20 units will need to be returned back to the Medicaid. That's pretty much it from me, and I will transfer over to Kia.
Hi there, Kia can't be with us today, so this is Melanie from MFD, and I will be presenting her slides. So I want to talk a bit about Mfd Recovery Action. So in the instances or the findings examples that Dorota reviewed, once an overpayment has been identified as a result of either an investigation or an audit, MFD initiates actions for recoupment of those improperly paid funds. And this can include MFD sending a notice of estimated overpayment or a notice of intent, and if necessary, a notice of claim. And in addition, MFD may add penalties, including false claim penalties that can range between $11,000 and $22,000 per claim. And MFD may also file a certificate of debt on real estate property owned by a provider or business owner. And MFD may seek a withholding of future Medicaid payments until the overpayment is satisfied. So that just gives an overview of the various actions that MFD has in their toolbox to pursue those overpayments. I also want to touch a bit on excluded, suspended, or disqualified providers. A debarred, suspended, or excluded provider is someone or an organization that's excluded from participating in a federal or state-funded healthcare program such as Medicaid. Any products or services that debarred individual directly or indirectly furnishes, orders, or prescribes are not eligible for payment under those programs. It's really important that that these exclusion checks are completed upon hire of individuals as well as monthly thereafter. More information can be found in newsletter volume 26, number 14, just to be sure that a debarred, suspended, or excluded provider is not within your organization providing services. Here's a list. I'm not going to go through it in detail, but this is the list of the various websites that should be checked for excluded, debarred individuals. I do want to touch on this last bullet, that if the provider is out of state, that you must also check that state's exclusion or debarment list. And I also want to mention self-disclosure. So there may be times that within your organization, you are finding things that may be of an issue. And we really encourage you to come forward and self-disclose those issues and return those in improper payments. There is a link on this website to the website. I apologize. There is a link on this page to the Office of the State Comptroller website's self-disclosure form, and that walks you through the process for how to complete and notify the Medicaid Fraud Division of those identified issues. The Affordable Care Act and NJAC 10.49-1.5 do require that any overpayments from Medicaid or Medicare must be returned within 60 days of identifying that they've been improperly received. And providers who follow those proper protocols for self-disclosure can avoid imposition of penalties. And again, more information can be found on the MFD webpage linked here. We also want to talk about third-party liability. Third-party liability exists when an entity or party is or may be liable to pay all or part of the cost of medical assistance payable by the Medicaid program. So examples of this include Medicare, commercial health insurance, and TRICARE. So by law, Medicaid is the payer of last resort, and all other TPL shall be used first and to the fullest extent to pay claims before Medicaid kicks in. It's a violation of Section 1902 A25D of the Federal Social Security Act to refuse to furnish covered services to any Medicaid beneficiary because of a third party's potential to pay for services. And now I'm going to hand it over to Joseph Jaraszewski from the Medicaid Fraud Control Unit.
Good afternoon. I'm a lieutenant with our New Jersey Medicaid Fraud Control Unit. In the United States, Medicaid fraud is a very serious crime, and it has very stiff penalties. To deal with it, our office has prosecutors, detectives, analysts, and auditors, and a nurse investigator dedicated to combating Medicaid fraud in the state. This work is so important that we are actually in the office of expanding our unit from 37 employees to 62 employees. Now, these employees solely focus on investigating and prosecuting Medicaid fraud and patient abuse, neglect, and financial exploitation. Our office does it through investigating both civil and criminal fraud. Our Civil False Claims Act section intercedes in qui tam cases, and the qui tam statute allows private individuals in the state to sue on behalf of the government. Those individuals have certain whistleblower protections, and they may receive up to 30% of any recovery So those two are substantial incentives for people to come forward and file those qui tam cases. If you can extend or go one more. Thank you. Regarding criminal fraud, some examples of crimes that we investigate and prosecute are things like paying incentives to patients to receive services at your facility, billing for patients that did not receive services on a particular day, or shortening the length of services provided. For example, having a patient in a group session for 4 hours and billing for 5 hours. Now, we use two main criminal statutes, and both of those focus on the falsity of claims submitted. The first one I'm going to talk about is our healthcare claims fraud statute. And under that statute, if you submit or cause to be submitted a false claim, and there's 5 or more of those and it's over $1,000, that would be what we call a second-degree offense in New Jersey. And for second-degree offenses, the maximum punishment is a 10-year state prison sentence. And you can also be fined up to 5 times the amount of the benefits that were sought to be obtained. Next slide. If you're licensed, you only need 1 false claim, and then you would violate that healthcare claims fraud statute, and it would be a second-degree offense, and you would be subject to that 10-year state prison sentence and that fine up to 5 times the amount of the benefits obtained. Also, there's a reckless provision in the healthcare claims fraud statute that makes it a crime even if you submitted false claims recklessly. For example, perhaps you're just billing off of your schedule sheet rather than off of who actually attends, and you're not trying to intentionally falsely bill, but you do it recklessly because you just do it off of that scheduling sheet. You could still get convicted of that healthcare claims fraud. Next slide. The second statute that we rely on heavily is the state Medicaid fraud statute, which makes it a crime to have a false statement in a claim to Medicaid. It also includes kickbacks and bribes, such as paying incentives to patients. Under that statute, there is a 5-year maximum state prison term and up to a $25,000 penalty for each false claim, in addition to any restitution that would have to be paid. Medicaid fraud is what we call a third-degree crime. Normally, for a third-degree crime, there is a presumption against incarceration for your first offense. However, the state takes Medicaid fraud so seriously that in the case of Medicaid fraud, if it is your first offense, that presumption does not apply, and you would most likely receive a state prison sentence. In addition to all the other penalties I spoke about for both healthcare claims fraud and Medicaid fraud, other possible consequences are exclusion from the Medicaid and Medicare program and the loss of your license. And to just kind of drive it home, ignorance of the law is no excuse for committing a crime. It's the provider's responsibility to know the law. I'll turn it back over to Melanie.
Great, thank you, JJ. So the following slides contain contact information, including email addresses, websites, and hotlines for the relevant state agencies and managed care organizations. And these resources are available to all of you, so please do not hesitate to use them. So I will just click through quickly. We have some contact information for mental health and addiction services. We also have included the various fraud hotlines. If you have concerns that there's something happening, you can reach out to the relevant area. And we have also included the third-party liability lines, both in English and Spanish. So if you have questions about that, please reach out. Now, before we wrap up and talk about questions, we would really like to hear how we did. So I'm going to put a poll up on your screen, very, very short. So please answer these questions to let us know what you thought. So I'll give everyone a few minutes to respond. Great, thank you. So I want to pause here and allow all of you to jot down this web address. This is a web address or email address, I should say, that I do monitor. So if in the future you have questions, you are welcome to use this to reach out, and we will do our best to triage and to get back to you with an answer. And I do want to stop and talk about the question and answer. So I believe during the presentation, many of you have been receiving answers to some of your questions. And what our plan is to consolidate those questions and share those answers more broadly, so that if some of you have the same question, that you are able to piggyback and benefit from those responses. I want to pause and turn it over to Steve Tunney to see if there was anything that came through in the Q&A that you felt would be worth sharing broadly right now.
Okay, let me look. Yes, I answered a couple of them, so let me look. So I know there was a question about billing for 90791 and 90792 on the same date service as the partial care program. And that is something that's listed for the 90792 code in the CPT manual. So that code's billed independently and should not be billed with psychotherapy or mental health services. So if you do the intake assessment, then start the services the following day. Can't bill for them on the same date of service.
Steve, we did receive a question asking, is partial hospital under the same telehealth rules as partial care after August 15th? Is that something you can speak to right now?
The per diem payment will go away on the same date, correct? So the partial hospitals were billing 5 units, but they'll have to stop and bill the number of units they actually provide. And the per diem unit with the GT is going to be termed effective 8/15.
And on a related note, and this may have sort of answered the question in what you just said, but there was another question asking if we could clarify if telehealth groups can be billed if they exceed 2 hours after August 15th, or is it only for in-person groups?
So all the rules apply. If you follow the telehealth law that went in 2021, it says any service that's provided via telehealth has to meet the same requirements as a face-to-face. So any of the rules written that are written for face-to-face would apply to telehealth as well.
And do those telehealth policies apply also to occupational therapy and speech therapy?
Can you say that one more time?
Sure. Does the telehealth policy apply to occupational therapy or speech therapy?
That's a little out of my wheelhouse. I can tell you that if the licensing board allows them to provide services via telehealth, then the answer would be yes. As far as Medicaid goes and paying for it, the individual boards are supposed to put out regulations about who can provide telehealth services under what circumstances and things like that. Medicaid is just the payer. We wouldn't make any of those determinations.
Thank you. And Dorota, if you're still on, can you speak to whether PCA needs daily, group, and weekly notes? Is that correct, that all three are needed?
Yes, that is correct. So the daily notes would be a documentation of attendance in the groups, and many times what we've seen underneath everyone's names attending the group, there is a short note summarizing the group events, and which would be pretty much a daily note. And then there are also notes that are required in participants' charts, which are weekly notes summarizing the progress or any events, unusual events.
Thank you, Dorota. You may also be able to speak to this question as well. So a question came in asking about time spent being transported to a community outing during partial care services. So the example provided says that the group is going to a store, and does the partial care have to deduct the time spent going from the facility to the store and back again from the billing? Is that something you're able to speak to, Dorota?
I think Steve Tony would be a better person to answer this question, probably.
So Steve,
Yeah, this comes up a lot. You cannot bill for services during transportation unless they're being provided. So if you had 10 people on a bus and you had the driver and there was another person there providing a billable service for the people that were in the van, then that would be allowable. But just driving to get to the facility to do the intervention would not be allowable.
Thank you. And on a related note, and again, Steve, I'm not sure if you're able to answer this in the moment, but there's a question regarding the transportation code Z0030. It says, besides this code, what about A0425 UC for mileage? So I'm assuming that's the mileage code. Is that able to be included with the transportation code?
Yes.
Thank you. I've got a lot of questions whether the slides are going to be available to participants. And so the short answer is yes. They will be circulated within the next day or so to all of you by email, and they will also be posted on the Office of the State Comptroller website. So they will be accessible for you to have at your fingertips and share them as well. One last question. It says, will Medicaid approve 650 units if clinically appropriate? Prior to the pandemic, priors were not getting approved for 5 days, 650 units. Steve, is that a question you may be able to speak to?
That's something that we have to readdress. I have reached out to the Division of Mental Health and Addiction Services to see how they want to call it. Originally, the intent was that we didn't want people getting the full 650 units, the 5 hours, five days a week, nonstop ongoing. We wanted to see progression towards less and less hours and people making progress. That somehow turned into you never would qualify for the full 5 hours a day. So I'm working on that with the division, and hopefully we'll have an answer soon. In Medicaid, anything that is medically necessary, we would cover it. So that would be my response.
Thank you. So I think with that, we've answered all of the questions we are able to answer in the moment. And what we will do is, if you have submitted a question in the Q&A attached to your name and email address, we will be able to follow up with you directly after, and we will also share responses more broadly for everybody who's on today's webinar. If you've submitted a question anonymously, unfortunately, we might not be able to get back to you directly, but we will do our best to include a response within a more broad response to all of you. I think with that, we are going to come to a conclusion of today's webinar. We really thank all of you for participating, for being a part of the NJ Family Care Program. We hope that you got something out of today's presentation, and keep an eye out for the slides that will be shared with you. And with that, we will wrap up today's webinar. Again, thank you all very much.